Thank you very much for coming to talk to us today. We're so glad that you're here, and we're going to talk today about the role of iron in neurovascular disease. I know you're all doing some important research related to that. So if we could first start just by going to each of you and talking about your individual work. Dr. Habib?
Well, iron by itself is a very important element in the brain. So when it behaves badly, you get to an unfavorable outcomes. Recently, MS has been diagnosed as having a vascular part, and then they relate this to iron deposition. However, in general, there is a big conflict in terms of what role does iron play. Does it initiate the disease? Does it exacerbate the disease? Or is it just a marker? And you will see, as Dr. Ropele has shown in his recent review, that older MRI techniques has shown that there is a correlation with the disease. However, the new ones are showing some conflict. Some of them are related, some of them are not. So it's really a huge conflict depending on how they attack the problem. It depends on what technique they use. So, for instance, some people are on iron supplement and they feel better. Some animal work, they just feed them low iron diet and they don't get the disease. So what's really going on is still a big area of research. In my work so far, we used phase-based image iron quantification, and we have seen a clear separation between MS and normal population. However, it didn't really correlate with the disease progression itself. In another group, they also saw, basically they used the same method and they saw that. So in a brief or amateur comment on this, I would say that how in real estate they say location, location, location. I believe in MS it might be the same. So it depends where the lesion takes place, you have this problem, or where iron deposition takes place, you have this symptom. So this is basically what I've been doing, and this is my understanding for iron, the role of iron in MS itself.
Okay, Dr. Connor, could you tell us a little bit about your work?
Sure. I think we've spent about 25 plus years now working on iron in the brain and looking at various diseases that are associated with it, MS, multiple sclerosis being one of them, Alzheimer's disease, Parkinson's being some of the more frequent disorders that we work with as well. The challenge really is for studying and appreciating iron in the brain is that it's very important for normal brain function. Without enough iron in the brain, we don't function optimally. But at the same time, if there's too much, as Charbel alluded to, it becomes very problematic. It's one of the most potent inducers of what we call oxidative damage. Everybody knows they should take their vitamin E, or they hear stories about taking your antioxidants. And what that really is doing is trying to control damage that's associated with too much iron, or iron out of balance, that's the way we like to refer to it. So where we've really been focusing and lately, and what I'll be talking about at this meeting is how iron gets into the brain, and where is that site of regulation. And the reason that we're here at the neurovascular conference is that we're really beginning to show that the regulation actually does take place at the site of the blood vessels. So how does the brain know that it needs more iron? What signals does it send out? When it has enough, what signals does it send out to stop the iron accumulation? As we learn about those signals, we'll be able to understand in disorders like restless leg syndrome, where we've shown there's not enough iron in the brain, what are the miscommunications there that are keeping iron out of the brain when you should have it? And likewise, what are the miscommunications that are allowing too much iron to come into the brain in certainly Parkinson's and Alzheimer's, and perhaps in multiple sclerosis as well.
Okay, thank you. Dr. Ropele?
So, as the other have already emphasized, is that there is no doubt that the iron metabolism is distorted in many inflammatory and neurodegenerative diseases, including MS. But we know so far only very limited about that, and what we need are sensitive and non-invasive technologies. And in this context, MRI is a very interesting candidate because it allows non-invasive and also sensitive mapping of the iron content. And that's actually also my research area. So I'm focusing on MR methods, new MR methods to better assess iron accumulation in different regions of the brain. And what we have learned so far is that there is significant iron accumulation in the basal ganglia of MS patients, which is related to disease progression and also cognitive decline, and also disability and atrophy. But so what we have learned so far is that, or our data, I would say that way, our data suggest that the iron accumulation in the basal ganglia seems to be an epiphenomenon of the disease and is a reflection of accumulated neurodegeneration. But that could be totally different in MS lesions and in white matter. But our current MR methods are not sensitive enough to prove and investigate the role of iron in lesions and in white matter. Because it is assumed that the iron in white matter is more directly related to disease activity, as it can cause or produce oxidative stress and free radicals, which in turn can trigger or at least promote the inflammatory and neurodegenerative cascade.
So how would you change the MR technologies to more finely be attuned to be able to diagnose something like that? I mean, what would be done that would make it a more appropriate tool?
Yeah, that's not easy. I mean, there are some developments underway. One is the trend towards higher field strength, because the higher magnetic field provides a higher sensitivity because the magnetic effect of iron is stronger. And that's just one of the steps we have to take.
What would be the downside to doing that? I mean, is there a negative side by having a higher magnetic field? Does it cause any other secondary implications?
No, it's just a question of availability. So it's not readily available.
Okay. This is a question I'll pose to all of you, whoever feels that they want to answer it. Is it something that can be controlled or manipulated in any way by diet? Dr. Connor referred to taking vitamin E or taking other supplements that might perhaps offset some of the implications. Is that something that seems to be a reasonable pathway?
We certainly know that a diet that's poor in iron, particularly during development, will result in iron deficiency in the brain, and there are, again, as Ropele alluded to before, there's cognitive issues associated with iron deficiency, poor cognitive performance, motor impairment that really persists even if the child was iron deficient during birth, and then pardon me, and then the iron supplemented, the brain tends not to catch up. We're finding out. So, like I said, I think the data are clearer from iron-poor diets than the idea that if you eat a lot of iron, you're going to take on more iron into the brain. There's some studies that suggest that might be true, but we know that the iron uptake into the brain is, as I was saying before, is very highly regulated. So it's somewhat difficult to override those regulations and end up with too much iron in the brain. We're looking at some mutations, some of which are genetic mutations, some of which are very common. The most common gene variant or mutation in Caucasians is actually associated with iron uptake into the body in general. We've been looking at that in the brain, and in fact, in the presence of these mutations, there is more iron in the brain. One of the things we've learned is the associated with that mutation is a fourfold increase for Lou Gehrig's disease, for example. So one of I think it's a very good question in that if we have a patient with Lou Gehrig's disease, should we be talking about modifying iron intake into that individual. And same with Parkinson's disease. Should we talk about sort of limiting the iron in the diet as a way of trying to limit the availability of iron to the brain?
Are people trying that? I mean, is there sort of cause and effect clinical trials going on that would be related to using diet as a control in each of these diseases?
Not yet, but the data are just so. Our data, for example, in Lou Gehrig's disease is about 5 or 6 years old, and it takes the field a while to adjust to new studies. Groups in around the world, actually, China, Netherlands, United Kingdom. Have found that Italians have all found similar results to we have. So there does seem to be a consensus building that we need to look at this, which is, of course, the first step. So hopefully that, along with some of the models that we're developing, are going to be able to convince people that that this might be worth doing. One of the problems you always deal with is that very sick people end up being iron deficient, and so it's always a concern. You don't want to take someone down a path of where they may end up with iron deficiency and anemia by modifying the iron content. So it's a real balance again, which is as we all know is our real challenge with working with iron. You got to get enough, but not too much.
And that actually raises another interesting point, which you were referencing before, which is that you're seeing in some of these diseases not enough iron is triggering the problem, but yet in some other diseases too much. So how do you as scientists determine how to create that balance and how to manage it then on the the patient treatment side?
I think again what's really helped us is the MR imaging data that these guys are beginning to generate, because once we can't sample the iron in the brain of living patients. So as the tools are improved and position us to say that we can see differences in brain iron content, then diet, it really becomes our only tool. We have in some disorders that we know are associated with iron deficiency. There's certainly intravenous iron supplements for the most severe cases, and looking at some of those in treatments, for example, in restless leg syndrome. But the flip side of that is trying to limit iron in the diet. If the data, MRI data, are telling us there's too much iron, that becomes a greater challenge, at least involving another aspect of treatment that's normally not included, which is the nutritional component as well.
Well, you were also talking at one point, I can't remember who referenced this, but about the genetic component related to how the brain is taking iron in. Is there some way to determine that and offset it for later years, to determine some sort of a genetic biomarker or something that could potentially help offset Parkinson's later in life, or ALS, or any of these other diseases that are implicated?
Yeah, I mean, that's a study we do have going on now, which is, if we know obviously the genetic makeup of the individual, we get MRIs to try and then assess the brain iron status, compare that to cognitive performance in a group that doesn't have the mutation, and at that point sort of coming together with all of the data that we can converge from as many different biomarkers, and imaging is a wonderful biomarker. We sometimes think of biomarkers as something we can measure in the blood or in some fluid, find a protein that's changed, but imaging is a tremendous biomarker. So I think with those bits of data, where we can go to a 55-year-old person who says, I'm starting to forget things, and should I be worried? Am I on the slippery slope, or am I just being a little forgetful? We can add the genetics, the imaging, and the cognitive performance, and say, when we see this profile, we are a little worried. So let's bring in a nutritionist. Let's back off the iron content. Or when we say, based on everything we're looking at in the brain, there's not too much iron there. It's just, you're too busy. Just pay attention to where you put your keys. That's all.
Well, and you raise another good point that goes back to Dr. Ropele's work, which is the use of imaging as a diagnostic tool. So what would be the next steps with that for your work, Dr. Ropele, to get it to a place where it's becoming a tool that's utilized everywhere in the world to...
Yeah, just again, the problem with iron mapping with MRI is still the sensitivity. So currently we are in a stage where we can reliably assess iron concentration in the gray matter and also in the basal ganglia. And we can demonstrate for many neurodegenerative diseases that there is an excess in iron accumulation in the basal ganglia that is related to the disease. But we have no idea how it gets there. But we are still limited in our sensitivity to assess iron level in white matter, which would also be very important to understand the course of the disease and the cause of the disease. So in recent years, it had turned out that one of the problems is the magnetic property of myelin, which counteracts the magnetic property of iron. So current strategies try to disentangle the effect of the myelin from the effect of iron, and maybe that's a road to the success.
Okay.
But these methods are still not evaluated and available. But that's the current research direction.
Okay. So what happens now? I mean, you have all conducted sort of bits of the puzzle that seem to weave together into a pretty good tapestry. Where does it go next? You've all come together at this conference and you're having an opportunity to collaborate and learn new things. Now what?
I mean, in MS, there are too many challenges, like in the technology itself and in the disease itself. One big thing, I guess Dr. Ropele will agree with me, that's hard is to quantify iron in the white matter where we see lesions. Because the lesions, anatomy or pathology by itself is so complicated. And as he said, we don't really have the sensitivity by itself to really be able to detect the right amount of iron there. And also, it's like in normal aging, iron does increase. So if this increase is normal, or not normal, this is another challenge. Try to understand what's really normal. And this is our baseline that we really agree upon to. Another thing that it's a challenge for us is adding new sequences to MRI and the conventional protocol that patient go through. Patient is there, he doesn't really need to stay too long. So whenever we add something that will add another time for him to be there, sometimes in the clinical world, it may not be acceptable by itself. So all these, the technology, the patient care, and the complexity of the disease lead to this, hard way to attack the problem and understand what's really going on. Also, the iron deposition along these three levels in MS, if you talk about the white matter and then the gray matter, and then you talk about the venous itself, because now if there is this venous congestion and then you have this microbleed, and then iron is leaking out or it's in the vessel wall, all these components, are still in the early stages of understanding. So we're trying to understand this whole scheme, from the source of the problem to what we really see in MRI, and then be able to assess what's really normal and what's really, pathogenic by itself.
I would agree, and maybe just add that where we are is at a very exciting point. We are now talking about trying to converge the information from multiple technologies and bringing us together in a meeting like this. So what's going to take us forward now is funding, and I know it's a difficult economic times, but we the baby boomers are there. We want to age well, we want to age healthy, and we want to continue whatever the sayings are now, the 40 is the new 30 and 50 is the new 40 and things like that. The data are really coming together, and the technology to help us. We can do imaging on living people and getting a handle on things like brain iron content, and we can do the type of cognitive testing that helps us identify which parts of the brain are being impaired or working normally. And we're learning that things like nutrition and exercise are important for healthy brain aging. So there is a convergence of ideas and a very exciting opportunity to keep things now moving forward. We're moving from the laboratory into translational research now with the tools that these guys are championing. And so it's not the time to pull back. It's the time to push forward, because for many reasons, including economic reasons, healthy brain and healthy brain aging is going to be better for us in the long run.
I just would like to add a comment to what the other speakers have
Please.
said. Actually, our knowledge about iron accumulation as a consequence of normal aging dates back to work that has been done in 1958, which is still the largest post-mortem study with chemical iron analysis. So there hasn't been added much so far. There's still a lot to do.
Okay.
So our knowledge about iron accumulation during normal aging is still very limited.
Okay. And Dr. Connor's point about funding is an important one that I think we miss a lot. How do you come to a place where you can get the funding that you need? Because private dollars are probably not going to be adequate to fund the breadth and scope of research that needs to be done, right? So how do you come to a point where you can convince governments and corporations and larger entities that really would have the power to make a difference that this really is something that's critical to fund?
Well, I think the issues are that we don't like to talk in terms of, it's better to bring up individual stories, and we talk about patients with Alzheimer's disease, mothers, fathers of the baby boom generation, and the baby boom generation itself now starting to face some of these questions. So on an individual basis, writing your congressman and trying to increase awareness is certainly important, but it's the NIH that has to, the National Institutes of Health, that has to lead the way, and then the government has to be responsive to that. And if we're facing a disorder such as Alzheimer's disease that's costing us $80 to $100 billion a year now, and the baby boomers aren't all there yet. You simply can't afford. And again, you want to talk in terms of human health, but if we talk in terms of economy, we simply can't afford not to do something about Alzheimer's disease. And the data are again, as we're here to sort of talk about iron, there is some substantial evidence that there's elevated iron in the brain in Alzheimer's. So is this somewhere that we could start and begin to look? So I think that's, it has to be, you're right, it's tough for private donors to make a huge difference. They certainly make a significant contribution, and they do make a difference, but to move the whole program forward, it has to come from government support.
So what's the critical component? What's the most important takeaway, or something I perhaps haven't asked you through the course of these questions? Charbel, anything we've missed?
From a therapeutical point of view, it's still too early to say, what does iron do in MS? There's no real conclusion what's going on. Even using the same technology, you are getting sometimes, good correlation, sometimes not very good correlation. So also, as Dr. Ropele was talking about the 1958 study where they did postmortem studies on the iron content in the brain, that was ex vivo, so we cannot really take it as a baseline of what we're doing now using MRI. So also the understanding of normal aging first, because if this is what the body takes over the time and this is how it happens, you may not want to treat that. So we need to really understand what's normal and what's abnormal. And this is something Dr. Hickey and Dr. Hewitt talked about when they said we need normal. We need normal data. Everything should be relative. So this is the first challenge. And until really you understand what's going on there, and what's the shift between normal and MS, people cannot really go into that. Also, as I said, there is a conflicting report in terms of some people go to iron chelation to reduce the iron content in their brain. They feel better. You have case studies, they feel better. And now I talked about another study done in 2011 they did iron supplement and they felt better. I mean, it's really, I'm talking not from an expert point of view, I'm talking from a student point of view who read these papers, and I believe I can take it from, the patient point of view. Okay, what approach to take? Right. So I believe there is no conclusion yet about this. We really need, strong normal data, and we really need strong MS patient data, and that's where collaboration will be really important. You asked a question before about what is really needed to get money. You need a complete project. You need the right technicians or the right scientists, and you need the patient pool, which the source is their primary care physician or the neurologist. So getting all this together and show the funding agency that, okay, we work as a group, we have some preliminary data why we're doing this, I guess this would lead to a successful project. So definitely collaboration is the right approach.
And you mentioned something in your comments about more normals, and we've had somebody else mention the Millennium Project. Will the iron in the brain, will there be an offshoot of that project to try to have more normals to look at iron concentrations in the brain to use as a greater baseline for comparison?
Yeah, definitely. The MRI technology is really expensive. You get like $1,000 per hour, depend on the rate you pay. It's really an expensive technology, and nobody will do it, out of pocket. And the clinical machine is really busy. I work on a research magnet, but I believe the clinical machine is really busy. So you need to get in, you need money. So yeah, especially creating the right protocol to create all the baseline data is really important.
No, it's absolutely, that's a really good point perhaps to close with, is that we need to know normal. And until we really get a good handle on normal, then in the MS, Alzheimer's, the different disorders, we're not going to really be able to plug in all the disease information that we're gathering into the right places and understand the disease. And so again, I think where people could get involved and make a contribution is call the local medical centers, look in the paper if there are studies that are ongoing, volunteer. You can MRI is non-invasive. It doesn't hurt, and it's and until we understand what the normal brain looks like, what the normal aging brain looks like, we're not going to be able to come in with those type of intervention strategies where we said maybe it's probably not, but gee, if it was as easy as decreasing your iron intake through your diet once you turned age 50. We could do that. We just don't have any evidence to say that's what you should be doing right now, and we don't want people becoming anemic or iron deficient. So until we can map out the brain and say, these are the normal levels that you should have, and as we've said, the iron in the brain increases with age, and that could be all well normal and good, but the MRI will help us there to gather that information, and then as I said, once we define normal, then we'll know what kind of intervention strategies we should start to develop.
Thank you. Any final words, Dr. Ropele? No? Thank you so much, gentlemen. This has been a great interview. I appreciate you being here.
Thank you.
Thank you.